This time, we're going to talk about occlusion for removable prosthesis. Regarding occlusion, there are distinctive difference between natural dentition versus denture occlusion. In natural dentition, the teeth are retained in periodontal ligament. Therefore, units or individual tooth moves independently. Therefore, malocclusion, if there is, affect not immediately because it only affect on affected tooth. Non-vertical forces affect only teeth involved and usually well tolerated. And incising in natural dentition doesn't affect posterior teeth. And therefore, in natural dentition, the bilateral balance occlusion is rare. And all the teeth due to the periodontal ligament, tactile sensitivity are present. So these are the characteristics of natural dentition. In natural dentition, one of these three occlusive scheme present, usually canine guidance, which is canine is the one that guiding the excursive movement, as is shown in this picture. And there are certain population does have group function, and this time it's a unilateral balance occlusion, which means only the working side will be in group function, not in the non-working side. The mutually protective scheme of occlusion also quite common in natural dentition. So the anterior teeth and the posterior teeth will protect each other while in the function. And this example of showing on the left side is showing the canine guidance of in natural dentition. And the right side of picture shows group function, unilateral group function picture showing. On the other hand, the denture occlusion are different. Its denture are basically seated on top of the soft tissue, which is mucosa. And all these teeth are moved as a one unit because it's in one piece. Therefore, any malocclusion affect entire base immediately. It's not individually separated, it's all in one piece. Non-vertical force affect all teeth and is traumatic. And also the incising affect all the teeth. And their bilateral balance occlusion are often desired for the stability of this removable prosthesis. And of course, due to the no periodontal ligament, it decreases the tactile sensation or sensitivity. So there are large two difference between natural dentition versus removable denture occlusion. Due to this fundamental difference, regarding the selection of posterior teeth for the removable, there are different options to choose. And there are 6 different options. And from anatomic, which is 30-degree, or semi-anatomic posterior teeth. And these two are lingualized occlusion. One is a regular lingualized occlusion scheme. The other one is lingualized occlusion opposing monoplane. So as you notice, the differences is on the mandibular teeth. And monoplane with the balancing occlusion. And the last one will be monoplane Eurocentric. The reason we have a many different occlusion scheme for removable prosthesis is well published in 1971. When the teeth lost, after patient lost the teeth, the alveolar residual which will continue on resorption, and depends on the time it passed, the residual ridge got more flattened, and depends on the shape. The resistance to the lateral forces will be different. For example, with the well-contoured alveolar ridges versus flat ridges, the lateral force resistance are significantly different. Therefore, when it comes to flat ridges, you do not want to have too much cusp angulation to reduce the lateral forces versus on good residual ridges. Still, you could provide anatomical shape of posteriorities. So that's the one criteria, but there are a number of criteria for posteriority selection. First one, of course, is resorbed or flabby ridges, ones we discussed already. And the physical condition of the patient also will be determining factor. When the patient has physical limitation in terms of their own muscle control, you may choose toward to the monoplane occlusion rather than anatomic side. And also the patients who clenching or bruxing habit also affect the choice of the posteriorities. And of course, the previous denture occlusion also have one of the reference that which occlusion scheme that we're going to choose. And the ridge relationship depends on the class jaw relationship. Class 1, which will be the normal occlusion, which will fall well with the anatomic or semi-anatomical teeth. But when patient has class 2 or 3, you may reduce the cusp height toward to the monoplane side. Another criteria is immediate dentures. And the last one will be opposing dentition or opposing arch. You need to look at what will be the opposing dentition, and depends on the natural dentition or another removable prosthesis are in the opposing dentition that will determine what type of the posterior teeth you're going to select. So the first, let's take a look at the anatomic or semi-anatomic teeth. Objective in setting anatomic or semi-anatomic posterior teeth is to create balanced occlusion. All posterior teeth contact in excursion as well as anterior teeth. When you look at this picture, this is a sample of full anatomical teeth occlusion showing maxillary and mandibular. And bilateral balance occlusion should be achieved in this setup, so that this is the initial setup of anatomical teeth. This is when is mandible move forward, which is protrusion, and you could notice that not only the incisor are touching, but also there's a posterior cusp are also simultaneously in contact. So it creates the bilateral balancing occlusion. This is showing of non-working side contact, and this bottom picture showing working side teeth contact. So by providing working and non-working side simultaneous contact is called bilateral balance occlusion. This is what you're going to practice with your occlusal adjustment exercise. You try to make bilateral balance occlusion in the denture that you receive. So this is working side movement. You could see all the teeth, posterior teeth, are in simultaneous contact. And at the same time, non-working side, which is the other side of it, should also be in contact together. Now, to achieve bilateral balancing contact. An anterior-posterior curve is placed in the arch called compensating curve, which is analogous to curve of Spee in natural dentition. So when you look at this diagram, from the lower incisor to canine, premolar and first molar major buccal cusp are in the same height, but when you look at the distal buccal cusp of a first molar, it's a half a millimeter higher, and the second molar major buccal cusp will be 1 millimeter taller than initial height, and the distal buccal cusp of second molar are in 1.5 millimeter higher than initial height. This is called the compensating curve and is showing curve of Spee, anterior-posterior curve. There's also another compensating curve. Mesiolateral curve is placed from the side to side, and it's called the curve of Wilson. So in this diagram showing molar teeth and the buccal cusp and the lingual cusp height are angled toward to the lingually, it provides the curve of Wilson. So these two are the compensating curve present for setting the posterior teeth to achieve bilateral balancing contact. You need to understand the Christensen phenomenon. To achieve bilateral balancing contact depends on the patient condylar inclination, which is on the left side is showing that the patient has a 20-degree condylar inclination, versus on the right side picture is showing the 30-degree condylar inclination patient. As you notice, the posterior teeth gap when it's patient protrusion are different spaces, depends on the degree of condylar inclination. So higher condylar inclination is more larger gap between the posterior teeth present when the mandible are in protrusion. So because the posterior teeth are separate when it's protrusion, you need to have a cusp height and cusp tip will be in contact at the time of incisor teeth will be in contact. So that's a protrusive balancing. And when it comes to the lateral excursive movement, when the working side cusp are contacting, the other non-working side or balancing side, the buccal cusp on the mandibular and the palatal cusp of maxilla will be in contact to achieve bilateral balance. So that, again, to achieve the bilateral balance, position of the second molar should implementing the curve of Spee, which is created by the slightly elevating the distal half of the first molar and by elevating the second molar by about 15 degrees up from the occlusal plane. So I explained this difference all the way to the major buccal cusp is the same height of occlusal plane, and then distal buccal cusp 0.5 millimeter and 1 millimeter and 1.5 millimeter gradually increase to provide a curve of Spee. The next occlusal scheme is lingualized occlusion. This is a diagram representing the lingualized occlusion. When you look at closely, maxillary teeth are fully anatomic teeth, but teeth are slightly tilted in a way so that the lingual cusp or palatal cusp are dominant cusp in contact, but the buccal cusp are not in contact. Mandibular teeth are about semi-anatomical teeth used to provide only the lingual cusp in contact, but not on the buccal side. So when compared to the anatomical or semi-anatomical teeth setup, this buccal side teeth will not be in contact, meaning on the lingualized occlusion, only the lingual cusp are in contact with the opposing lower teeth. This is a more better view and larger view for the posterior teeth. As you notice, lingual cusp are in contact, but it's actually the buccal cusp will be open contact. So this is showing lingualized occlusion setup in the posterior teeth. Is it lingualized occlusion does have a balancing occlusion? The answer is yes. The way it achieves bilateral balancing occlusion, when it's in balancing slide, it has a buccal side corner will be in contact with the lingual cusp. When it comes to working side, it actually the lingual side of the mandibular teeth will be in contact with the maxillary lingual cusp. So it's always, whether it's balancing side or working side, only the lingual cusp, maxillary, are in contact with the occlusion. Therefore, it's called lingualized occlusion. It does have some advantage. It is provide good aesthetic because maxillary teeth use are anatomical teeth, fully anatomical teeth, meaning as close as natural dentition. So it's good aesthetic compared to monoplane teeth. And also provide a freedom of non-anatomic teeth, meaning due to the no contact on the buccal cusp, it's only contact in the lingual cusp, provide the freedom of movement of the lingual cusp without locking in certain position. It also have a potential for bilateral balance, and also it centralizes the vertical force. And as shown on this diagram, when the patient chewing a food, it centralizes the vertical force down to the center of the mandibular molar teeth. And it minimizes the tipping force due to much less lateral force generated in lingualized occlusion. When you're setting up lingualized occlusion, posterior teeth form, there should be little or no curvable Wilson. We discussed about two compensating curve. One is curve of Spee and curve of Wilson. And for the lingualized occlusion, you do not provide curve of Wilson, which is buccolingual tilt. In this setup, both the lingual and the buccal cusp tip of the premolar and the first molar are on the plane of occlusion, meaning this buccal cusp and lingual cusp of mandibular molar will be in the same occlusal plane. So we didn't provide any curve of Wilson on the lingualized occlusion. In prefabricated denture teeth, you could identify whether these teeth mold are lingualized occlusion by looking at lingualize. That means these teeth are generated or manufactured for the lingualized setup. Same thing on the mandibular teeth. And this is showing you mandibular lingualized teeth setup. Teeth set. So even in the lingualized occlusion setup, still the bilateral balancing should be achieved and established during the manufacturing. And second lingualized occlusion is using the monoplane in the mandibular teeth. So before the original lingualized occlusion, it used a lingualized maxillary and lingualized mandibular, but when it comes to lingualized monoplane occlusion, we use the lingualized maxillary teeth, which is full anatomic teeth, and mandibular has the monoplane teeth, which is as shown in this picture, and the buccal lingual cusps are completely flat. And this is also shown in the prefabricated denture teeth set. It shows the plane, meaning it's monoplane denture teeth set. So this is showing you the example of lingualized monoplane teeth setup. And again, only the lingual cusp of maxillary teeth are in contact with opposing, and the buccal cusp should not be in contact. And mandibular teeth will be set in completely flat surface following the monoplane setup. The next occlusal scheme is monoplane setup, and maxillary mandibular teeth, when you look at the cusp, are all flat. And plane of occlusion is completely flat and level. There is no curve of Wilson or curve of speed, which is no compensating curves, incorporated into the setup. There is no vertical overlap of anterior teeth. Allow the teeth freely move anterior posteriorly. When using this concept of occlusion, the patient is instructed not to incise the bolus. With this tooth arrangement, Divan noted that the patient will become a chopper, not a chewer or grinder. Basically, the monoplane teeth will use the open and close vertical movement rather than lateral grinding motion due to no cuspal inclination in the teeth. When it comes to monoplane, as is described, the anterior teeth do not have any vertical overlap, and posterior teeth will be set completely flat. In this setup, when the patient moves protrusion, the posterior teeth become separate due to the Christensen phenomenon. So this is the monoplane setup, maxillary mandibular. When the patient protrusive movement or incising with the front teeth, as you notice, due to the condylar inclination and Christensen phenomenon, the posterior teeth will separate it, has no contact. In monoplane occlusion, class 2 patient, the mandibular tend to travel farther anteriorly in function than the typical class 1 patient, and consequently, more horizontal overlap is necessary to allow for this functional movement. So class 2 patients tend to move a lot more greater range of protrusion. Therefore, you provide greater horizontal overlap. Monoplane teeth will be set completely in flat, and this is showing you the full teeth are set in flat, and depends on the condylar inclination, the posterior teeth will be separated. So now you may have in question that how we make a bilateral balancing in monoplane teeth. In monoplane teeth, the stiffer the condylar inclination, the greater the posterior discrepancy in excursion, and the greater the need for balancing ramp. In all lateral excursions, you should observe at least 3 points of contact bilaterally, right and left balancing ramp and anterior incisors. So to achieve bilateral balancing occlusion in monoplane, we are making balancing ramp is showing right in this distal from the second molar, you could see there's a large wax bump. And this wax bump will be creating the second and third reference contact point when it's incising, protrusion, or lateral excursive movement to allow us to having bilateral balancing contact. So this is regular in closing, and this is when the mandibular protrude, and as you see on the second molar of maxillary teeth are in contact of this wax bump. It's called the balancing ramp. And these are how we provide making monoplane teeth in bilateral balancing. So we discussed about 6 different posterior teeth setup from the anatomic, semi-anatomic, lingualize, and lingualize with opposing monoplane, and monoplane with balancing, and this is monoplane Eurocentric. When it comes to the occlusion, it's extremely important to provide the CO contact first. And let's take a look at this video. Slowly close. One more time, open and close. Slowly, slowly. So I wonder how many people will notice whether the occlusion is right or is occlusion has a problem. Let me show you one more video. Close gently, and the same thing. If you feel something touch, stop it. Open. One more time. Close. Open. One more time. Relax. And gently close until open. Relax more. Gently touch. So these two has one difference. Left video is taken without having any denture holding in place in the mandibular. Right side, you notice very obvious occlusion is off because I was holding the mandibular denture in place. So when you check the occlusion in denture, be careful not to rely on the patient habitual bite because the denture may move and shift, so you will not be able to recognize the malocclusion or occlusion error. On the other hand, when you are checking the occlusion on like the right side, if you're holding the mandibular denture in place, then it's very clear to see the occlusion how far is off. And this is more clear view. After this is a clinical remounting, let's see how much occlusion is off on the same denture. As you notice, this denture only have second molar contact, no other teeth. So this is happen when the occlusion, initial bite registration has error, then the final denture will not be in correct occlusion. Let's take a look at another case one more time. Close slowly. Close. All right. How many of you recognize any occlusion error? Did you find any in regarding the error in occlusion? I will show you second video. Relax more. and slowly close and gently touch. Don't close more. Get close to the left. You see the gap? Open. Okay. So I believe that you could be able to see the gap in one side clearly on the second video. And this is how actually what happened intraorally. It's only one tooth are holding it up and no other teeth are in simultaneous contact. And this is after we adjust occlusion to achieve bilateral contact. When there is occlusal discrepancy, then you need to take the new bite registration intraorally and so that you could adjust in the articulator when it's needed. So in this particular denture, try-in, we identified there is an occlusal discrepancy. Therefore, we took the bite registration. And now, this is the sequence that how you're going to adjust occlusion when the occlusion is not right. The first thing is initial mounting it, you are checking which posterior teeth are in contact. In the try-in denture, you should be able to see all the posterior teeth, including premolars and molar, should be in the contact. In case that you don't see all four teeth are in contact line, then you need to adjust any existing contact until all the four posterior teeth are in simultaneous contact. So that's the first thing. We call the CO occlusal adjustment, centric occlusion, occlusal adjustment. You achieve this one until all the premolar and molar are in contact. Once you achieve that one, now you are checking working group function, working balance. In the working balance, in the working side, if there is only few teeth in contact rather than in group, then you need to adjust existing one or two teeth in contact so that other four teeth cusp are simultaneous contact during working movement. In that one, you are adjusting following BULL rule. Is Bucker upper and LL lower lingual. So this one is called the BU and L lower lingual cusp is the one that is adjusting. So when you see the checking mark, you will have a mark on the upper cusp and lower, whereas both sides will be marking articulating paper. In that case, you are not touching functioning cusps. On the inside, when this palatal cusp and lingual cusp are in contact, hypermark, you only adjust lower lingual cusp, not the palatal cusp, which is a functional cusp. So when you're adjusting working side, you follow BULL, called the Bull's rule. When it comes to balancing side, you are adjusting slope of the functional cusp, if there's any. So let's take a look at initially on the working side, you notice only 1 and 2 contact. None of these three teeth are in contact. So this one, you will see the mark over here and mark over there. You need to continue adjusting in this hyper contact until all these four teeth molar and the canine are in contact, like here. So let's take a look at and this is the other side. Same thing happened in the working side. So only canine are touching. none of the posteriorities, meaning right now the denture has a canine rise, canine guidance. So you need to adjust starting from the canine until all four teeth are in simultaneous group functioning contact. So this one, this is once you finish all the contact, you can see entire working side cusps are in balance, in contact. The other side, this is when you finish all the adjustment. You notice all the cusps are in contact together. So that's how you adjust the working side following BULL rule.